Hi everyone, I'm Shannon with Camelot Care Centers, and I would like to welcome you to our first series of training videos for our in-home counselors and in-home therapists. Over the next several weeks, we will explore various diagnoses, interventions, treatment plans, among a host of topics that pertain to what you will encounter when you provide care for children, adolescents, and families in our community. Today, I want to give a brief overview of one of the most prevalent diagnoses for children, and that is attention deficit hyperactivity disorder, also known as ADHD. According to the DSM-5, ADHD is a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with development or functioning. ADHD presents primarily in three different types. It's either predominantly inattention, predominantly hyperactivity impulsivity, or a combined presentation of both. If it's predominantly inattention, then 6 or more of the following symptoms have persisted for at least 6 months and impact negatively social, academic, or occupational activities. Such symptoms include: one often fails to give close attention to details, for example, careless mistakes on schoolwork. One has difficulty remaining focused on tasks or activities, for example, listening to a school lecture. One often doesn't seem to listen when spoken to directly, and this may appear as if the person is spaced out when you're speaking to him or her. One often doesn't follow through on instructions and fails to finish tasks. One often has difficulty organizing tasks and activities. One often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort, for example, schoolwork or completing one's homework. One often loses things necessary for tasks or activities, for example, the proverbial question, "And why didn't you bring your school books home today?" Or, "Have you lost your pencil again?" Or, "Where are your school supplies?" One is often easily distracted by external stimuli, or often is forgetful in daily activities, for example, doing chores or running errands. If it's predominantly hyperactivity impulsivity, then 6 or more of the following symptoms will be present and again impact negatively social, academic, or occupational activities. Such symptoms include that one often fidgets with or taps hands or feet or squirms in one's seat, often leaves one's seat in situations when remaining seated is expected, often runs about or climbs when it's not appropriate to do so, often is unable to play or engage in leisure activities quietly, often is on the go or it is driven by a motor, so to say, and these typically are people that are difficult to keep up with. Often talks incessantly, often blurts out an answer before a question is even completed, and we oftentimes see this in the context of the classroom. Oftentimes has difficulty waiting his or her turn, and often interrupts or intrudes upon others. Now, additional criteria include that several of these symptoms were present before the child or the person is 12 years old, and these can be inattentive or hyperactive impulsive symptoms. That several of the symptoms are present in 2 or more contexts. Now, this can be at home, work, school, maybe church, etc. And there needs to be a clear evidence that the symptoms affect the social, academic, or occupational activities. And then finally, the symptoms are not better explained by another disorder. Now, I want to present 3 interesting facts about ADHD. The first is that many consider the disorder to be due primarily to a neurochemical disturbance. It's likely that there is a dysregulation of dopamine genetically transmitted in the frontal cortex of the brain. The second interesting fact is 1/3 of children with ADHD will outgrow the disorder, and that's good news. Unfortunately, that leaves 2/3 of children with ADHD that will experience ongoing symptoms for the duration of their lives. The third interesting fact is that the diagnosis is based mainly on 3 sources of data. The first is family history. ADHD runs in families. The second is a careful history of the nature and the onset of behavioral symptoms. And the third, we need to know the current symptoms, especially as it relates to how these symptoms vary across different contexts. And once again, it's important to know the behaviors in the home, at school, at work, maybe at church, etc. So what are some popular medications that you may hear about for people that have the diagnosis ADHD? There are three primary categories of medications that you will hear of. The first is stimulants, the second, antidepressants, and the third, alpha-adrenergic agonists. Examples of such stimulants that you may hear of are Ritalin, Concerta, Focalin, Vyvanse, and Adderall. Examples of antidepressants that you may hear of are Wellbutrin SR and Strattera. Examples of alpha-adrenergic agonists are Tenax or Intuniv. That concludes our overview of the diagnosis ADHD. Thanks for watching.
If I were to ask you, what are some of the 4 most common letters that you hear today concerning mental health in children? You would probably say ADHD. It's one of the most common diagnoses we see as counselors and therapists. We deal with it on a daily basis. The CDC tells us that 1 in 9 kids is diagnosed with ADHD in America, and that was as of 2011. So it's becoming more and more relevant to our culture and to our job. So the question then becomes, how do we deal with it? How do we approach it as counselors? How do we approach it as people coming into the home to try and help? I know for me, as a father, finding out that my oldest son has ADHD was very challenging for me, because I used to want to help the kids and try to fix them. I didn't want to realize that that was real. Now that it's in my family, it is all too real. And I have had to learn how to adjust, how to change my way of thinking from how I was raised to help him and try to teach him proper tools. So that's the purpose of our video today, is to give you an introduction, to give you an approach, how to look at ADHD. How do we treat it? As counselors going into the home, what do we do? How do we start? Where do we go? So what I've developed to help us is what I'm going to call the 5 B's of ADHD. We need to understand how to approach this. When we sit down with families and as counselors, when we develop treatment plans and goals, what are we trying to do? And this even applies to the teachers, the people that work with the child outside of the home. So the first B I want to share with you today is be realistic. Start with goals that the child can achieve and improve on in small steps. We have to be realistic. A child with ADHD cannot complete 7 tasks at one time. I know in my home, to tell my child, pick up your clothes, pick up your toys, go brush your teeth, put on your pajamas, and go to bed, turned into one of those things being done or nothing at all. This is ADHD. And many times with parents, we get frustrated, we feel disrespected by that, and as counselors, it's our job to try to teach these parents, you have to be realistic. Your child is at a disadvantage because of this issue of ADHD. Well, it's not really an issue, it's a diagnosis. So we have to teach them, be realistic with your child. Yes, you want to set goals. We want to establish structure, but we want to be realistic. We don't want to put more on the child than what they can do or what they can reasonably handle. When you're setting goals, make them precise goals. Make them to the point. Don't leave them broad and open to interpretation, because children will find the loopholes. But be realistic. Don't set goals that are too high and too lofty. Start small. Don't try to change everything about the child in one setting or in one treatment plan. Identify what the major issues are and start with that. But again, be realistic. Second B, be consistent. Repetition is a wonderful teacher across different times of the day, different settings, and with different people. Consistency is something our families are very much lacking. We live in a society that is very busy. We go here, we go there, we work, school, sports, dance, whatever kids are involved in. Personally, I have 3 kids in elementary school. They play 3 different sports. We're somewhere every day. So the key to that is we have to build consistency and repetition into their lives. Children do not function in chaos. We know that. It creates chaos and they cannot thrive in that. So how do we fix that? Well, we have to create consistency for them. Make a routine. But when you're establishing that routine, you have to be realistic. You can't establish a bedtime of 9:30 if you don't get home until 9:45 3 days out of the week. You can't be consistent that way. You're setting yourself up for failure. So we as counselors, we try to help our parents to be consistent, to establish repetition. Repetition is one of the best teachers that we have ever seen when it comes to mental health and the teaching applications. Thirdly, and this is important, we must be patient. Kids with ADHD will try your nerves. The parents are on edge, and sometimes we as counselors can get on edge too, trying to help these children. We must help our parents understand they must be patient. Don't expect instant changes. Teaching and learning takes time, and improvement will be gradual. Your child, once you establish these with the parents, help them to understand that tomorrow when their child wakes up with a new behavior plan or chart or new structure, they're not going to be perfect. All the behaviors aren't magically going to disappear. They're still going to be there. Now, there are some kids who will improve overnight, but as a general rule, most of them will still struggle, and they'll have to have you to be consistent and to be realistic. So you must be patient. Help your child. We've got to teach them. Your child is going to make mistakes. They're kids. They're going to mess up. They're still learning. They're still growing. So when we create the charts, when we create goals, when we set goals, and when we create structure, when that day happens, when it falls apart and we start getting phone calls, we've got to reinforce to our parents, be patient. We've got to help our kids understand, be patient, because in their mind, everything is running 1,000 miles an hour, and they also have to learn to be patient. And we as counselors must learn to be patient. It's very crucial. Things are not going to change immediately. It takes time. The average length of time we spend with the family is anywhere from 3 months to some of them up to a year, depending on their situation. It takes time. So we must be patient to teach our parents to be patient. So hopefully it's instilled in the children. The fourth B, be flexible. Constantly monitor the child's responses to your plans and your goals and adjust them as needed. Sometimes we'll make goals. We'll help the family establish a treatment plan or goals or a behavioral chart, things of that nature. And sometimes as the days and the weeks go on, they just need to be changed. They need to be tweaked a little bit. Help your parents to understand, be flexible. It's not disrespectful if the child can't operate under the goals that we've created. Sometimes you just have to change it a little bit, and it's okay. We have to be flexible. As counselors and therapists, we have to be flexible also to understand that, our first plan that we put forward, it may not work, and we'll have to change it up a little bit. So we've got to be flexible while we're being patient, while we're being consistent, and while we're being realistic. We have to do those things. And lastly, in the fifth B, we'll call this being proactive. Begin interventions as early as possible. Although behavior modification works for all ages, early treatment is more effective than late intervention. We've got to be proactive. When you see a child with those early stages, and we need to teach this to our parents, if they have younger siblings in the home. We're seeing in our field now that little brothers and little sisters are growing up. Some of them have ADHD, some of them just have behaviors that look like it. The more proactive you are in addressing behaviors with behavioral modification and psychotherapy, the better it's going to be. So it's our job to empower our parents, to give them these tools, to help them to be realistic, to be consistent, to be patient, to be flexible, and to be proactive. Another area this applies to briefly before we go today is the area of discipline and consequences. We need to teach our parents, be realistic. If they drop a bowl of cereal, we can't take away a week's worth of vacation or video game time. The punishment's got to fit the crime. It's got to be consistent. If a parent tells a child this is what's going to happen, they have to follow through with that. We've got to instill that. They've got to be patient. Children will push limits, especially kids with ADHD. They thrive in chaos. We've got to try to change that chaos. They've got to be patient. We've got to be flexible. We've got to be proactive. And I believe these 5 B's are a good approach to ADHD. This is by in no means all that we'll need to know, but it gives us a place to start. So I hope this helps you in your goal and your task to try to help families. ADHD can be very scary, but once we know, we can begin to grow. Knowledge is power. Good luck.